I'm Shari Potter. I am one of the co-chairs of the Parents Leadership Community, and we are super, super grateful that you guys are all here tonight. And I got to tell you, I am looking out at you all, and my heart is full because, we're all here. We're all here together, and I am very grateful. And I think that we are all here to discuss a topic that is very near and dear to us. And, I think that as BRCA mutation carriers, obviously our concern is about our own health, but for me personally, the most important thing is that I know that there's a 50% chance that I can pass this along to my children, and that's way more pressing in my head than my own well-being. And so we started this PLC, the leadership community, because we know that this is a topic that you all will share in caring about, and that we hope that you will recognize that you're not alone, and that when we do these discussions, it's an opportunity for you to realize that there is a community out here, and everybody has their own personal story, but hopefully you can glean some comfort and some information from what we're sharing tonight. And also, we want to keep you informed of all the amazing things that the Vassar Center is doing in terms of research and outreach and things like that. So tonight, you're going to hear from Vassar Advisory Board members Heidi Rieger and Susan Getz. Thank you, Susan, for spearheading the organization and planning and support of this event. You were incredible. And then the Vassar Young Leadership Council co-chair, Jenny Sorin. Vassar Center Executive Director, as we all know, Dr. Susan Domchek, and Associate Professor at Penn's School of Social Policy and Practice, Dr. Allison Werner-Lin.
Yeah.
Thank you. You have their bios on the information on your chair. And our panel tonight will be moderated by the inimitable journalist, Jill Warman-Harris. So Jill has a background in bioethics and has written for several medical journals, the New York Times, the Jewish Forward. She has an unbelievably masterful way of distilling and directing the most difficult topics into digestible and informative discussions, and we're always so grateful to have you on our Vassar team. Special thank you to Jonathan Adler and his team for allowing us to enjoy this really phenomenal brand new space, and for generously offering all of you 10% off of anything you buy this evening, and then I believe 10% of the proceeds of things sold during the week will be donated to the Vassar Center. And who doesn't like a discount? I mean, Paul would be proud, right? This is for Paul. So, exactly. And after our panelists have shared their stories, Jill's going to lead a Q&A, and we've received some questions in advance, and if there's time, I think we can also take some from you all. Don't forget to silence your phones and sit back and listen.
Come on. Yeah, exactly. Yeah, okay. Can you all hear me? Yeah? Okay, thank you, Shari. Hi, everyone. Thank you all for coming tonight. I am really excited to be here to talk about the lived experience of BRCA mutation carriers. You know, there are so many complex aspects of genetic predisposition, and tonight's topic, the tremendous impact that BRCA can have on family dynamics and between family members, is no exception. So I'm thrilled to have 5 outstanding women on my panel. I'm a really big believer in women supporting women. 2 very insightful clinicians, and 3 BRCA mutation carriers who will share their very personal stories about the multidimensional, never simple adventure that is BRCA. And I was thinking about it. It really is a quest. I like a line that I heard recently that says, "You can't be at peace until you gather all the pieces." So let's gather the pieces together through these compelling stories of experience, strength, and wisdom. So I'd like to start with Susan Getz. As Shari said, a Vassar Center Advisory Board member and someone who I'm privileged to call a friend. Welcome, Susan. In today's world, we speak a lot about previvors, but before BRCA was even discovered, Susan, you became a breast cancer survivor, which at the very young age of 32, with no known family history, was sort of unimaginable. At the time, you had a young son, Ernie, who's now in his early 30s, and years later, you had your beautiful daughter, Annabelle, who's now 24. Like all personal stories, yours isn't linear. It's made up of peaks and valleys, which you have navigated with characteristic grace. So do you want to tell us a little bit about how it all unfolded for you?
Thank you, Jill. Yeah. Well, Jill mentioned a few.
No.
Okay, better? Thank you, Jill. Jill already mentioned a few things I was going to say, but I was 32. It was 1990, pre-BRCA mutation, pre-Pink Ribbon campaign, and a woman that I knew, a mother of my 2-year-old son's friend, had metastatic breast cancer at 34 years old, and I just was freaked out by that. And I said, I'm getting a mammogram. And I made an appointment, came around 3 months later. Maybe I felt a little something about a week before, and the doctor said, have you felt this? I'm like, oh, I'm getting my period. Turned out to be a lump, turned out to be cancerous, as you heard, and it was quite shocking. I mean, it was just out of the blue. Had a mastectomy. In those days, singles. People didn't really do doubles. There was no reason to. And chemotherapy, and sort of got through it okay. I waited a long time to have another child, and I don't really know what the current thinking is today, but the thinking then was, one, you want to make sure you're around to take care of the other child, so that the cancer doesn't come back, and two, estrogen can, in some tumors, can fuel tumor growth, so you don't really want all that extra estrogen flooding your body. But I did have another child, and I was 40. In the meantime, I skipped a part because I'm not reading. I was asked a couple years after my diagnosis to participate in a study at Memorial Sloan Kettering about a breast cancer mutation. So I gave them my blood, never heard anything back, never got a call from them. And of course they discovered the BRCA mutation. I read about it, I knew about it. It was BRCA1. Then I had my daughter, and I said, I really want to know. So I called them up and went through whatever red tape, and they said, no, you don't have BRCA1, but now we have BRCA2, and you should come in. So I went in, and they took my blood, and I had BRCA2. By then, I had had my daughter, so that was good news. Had genetic counseling there at Memorial, and what I remember about it, I don't know if it was selective memory, but what I came away with was, okay, I need to take my ovaries out, but there's a curve, and I'm more likely to get ovarian cancer as I approach 50. And again, this was still quite a while ago. And there was still a large chance that I was going to get breast cancer in the other breast, but selective memory, I don't know why I didn't really act on that. I just did not want to have a prophylactic mastectomy. I was like living my life, busy, working, 2 kids. It's just no. So time goes by, and I do eventually get my ovaries out when I was 48. Again, somebody I knew had terminal ovarian cancer, and I was like, okay, these got to go. So I took them out, and I also thought that it would perhaps give me some protection against another breast cancer because, there's no estrogen and fueling tumor growth. But it did not work, and the oophorectomy worked, but I did get cancer again in 2009, and I was 50, and it was not as easy the second time, and I had another mastectomy, and I had more serious chemo, and there I am. And there's certainly been medical repercussions from these health situations. Treatment as well as, taking out your ovaries. Obviously, 48 is not terrible. But yeah, here I am.
Yep, here you are.
64 tomorrow.
And looking good. So I want to pause pause for a second and bring in Dr. Domchek. Susan's story shows how early onset can be for mutation carriers, and it also shows how they're more likely to experience what's known as contralateral cancer, which is a new primary in the other breast. It's always helpful to have medical knowledge as a framework before we get into these discussions. So can you tell us more about what the risks are for BRCA cancers, why we can't test for BRCA mutations before 18, and what is magical about the number 25 for carriers?
Is that it? Is that all?
Yeah, just that.
Just check.
You have 3 minutes.
Yeah. So BRCA 1 and 2, and again, it stands for breast cancer 1 and breast cancer 2. They're just the names of the genes, and we're not that creative, so that's what they are. We all have BRCA 1 and 2. They create normal proteins in our cell which help repair DNA damage. So when you inherit a bad copy or a mutation, or now we call it a pathogenic variant because we like to try to mix it up just to confuse people. But if you inherit a bad copy that doesn't make the protein normally, that's when you're at increased risk for cancer. So the two, BRCA 1 and 2 are related, but they're a little different. So BRCA 1, the lifetime risk of breast cancer is up to 70%, and those are largely what we call triple negative breast cancers. Estrogen receptor negative, progesterone receptor negative, HER2 negative. And the reason that matters is because when we're doing counseling, we talk about the fact that even if you are diagnosed with an early stage breast cancer through screening, which screening detects early stage breast cancers very, very well, but we still sometimes need to give chemotherapy because that's how we treat those cancers. And with that, most people have a very good prognosis. But again, that doesn't mean that people want to go through that experience, as Susan described. The lifetime risk of ovarian cancer is higher for BRCA 1 than BRCA 2. The lifetime risk of ovarian cancer is up to 45% for BRCA 1, and that's why we don't have good screening, so that's why we strongly advise removal of the ovaries. We might get into later about whether or not the fallopian tubes, that's going to be a thing or not, but right now we still advise removal of the ovaries between ages 35 and 40. So BRCA 2 is a little different. The cancers, still the lifetime risk of breast cancer for women is up to 70%, but more often they're estrogen receptor positive, as you just heard, and that sort of has some different implications for how we treat things. The lifetime risk of ovarian cancer is more like 20%, and it comes a little later, so we let people, if you will, keep their ovaries a little longer before we really strongly advise that the ovaries are removed. But BRCA 2 is where more of the risks to men come in. So the risks of pancreatic cancer for both men and women are about 7% lifetime risk, where for BRCA 1 it's like 2 to 3%. The risk of male breast cancer is higher for BRCA 2 than for BRCA 1, and the risk of prostate cancer is very much higher for BRCA 2 than BRCA 1, and those prostate cancers are more aggressive. So those are sort of the general comments. Developing any cancer before age 25 is exceptionally rare. So 25, admittedly, is kind of an arbitrary number, but is sort of based on when the risks start to go up and when we start to screen. So that's basically for women at 25, that's when we start breast MRI screening. We don't really do much for men until later, more like 35 to 40. But if women and men are interested in using this information as part of starting their families, and they happen to be wanting to have kids before age 25, which is hard for me to imagine, but it does occur, then reproductive planning is another reason that we consider genetic testing earlier. The reason that, in general, multiple medical societies have said not to test before age 18 is just because there are no significant increased risks to children, and we don't do anything different to children. Children is an interesting term, but children as defined legally is under age 18. And so that's why we talk about testing after age 18. They're adults. They, if you will, can make their own medical decisions about when they wish to be tested. So medically, we change things when people are about to have their kids, or for women at 25 and for men later. But we talk to 18-year-olds. Some want to get tested for various reasons. Others run from the room when they hear that they don't need to do it at the time. It's very individualized, and I'm sure we're going to be talking about that some more. And then the last really quick thing, parenthood after breast cancer, which is important. Getting pregnant, it's very well established now that getting pregnant after breast cancer diagnosis does not increase your risk of recurrence, which is really, really important, and it's part of our counseling, and I just wanted to throw that out there.
Yeah, it was a long time ago.
Yeah. Susan, I really want to talk about Annabelle, your daughter. As early as the age of 10, she was a breast cancer advocate, in a way, going to Tickle Pink events with you and doing mother and daughter modeling for fundraisers. She really grew up in the context of your second diagnosis. How did it impact her childhood and who she is?
Unfortunately, she's not here to answer for herself. She really wanted to be, but she moved to the West Coast and couldn't be here. It just was a part of her life. I actually called her this week to talk a little bit. And I mean, it was as early grade school that she knew. I mean, she said, "Mom, you had one boob." I mean, she knew something was up, and she was always a very intellectually curious kid. And it was just really matter of fact. I think you have to know your child and what they can handle. And Annabelle was just very, I don't know, she was very sensible and pragmatic, and it was very matter of fact. And she took it right away. We had been to a Tickle Pink event, and she said, "I want to work on that." And it was a breast cancer fundraiser, and she actually met Jenny and grew up with Jenny. She's younger by a couple of years. And she was involved all through middle school and high school with breast cancer advocacy. So it was like part of her DNA. And I don't think she really intellectualized that it could be her until, really those junior, senior year, high school. And she knew about the Vassar Center. Obviously, we did fundraising. And, she knew this was a genetic mutation that she could carry, but it really wasn't until that age where she started to panic.
Tell me a little bit about the panic.
She doesn't like to talk about it with me. I mean, mother-daughter relationships are tricky. And there are certainly certain things that are hot topics. And it's really not something we've talked about a lot. She made it clear very early on, I want to wait till I'm 25. She did start screening at 22, which is 10 years before my onset, which is what is standard practice, or advisable. And she very much, like a lot of young people, I want to have a partner. I want to be established in my career. I can't stop everything to do this. I need to finish everything. And she was very anxious about it. And I actually called her this week. I said, "We haven't spoken in a while. Like, where are you in all of this?" She goes, "I can't talk to you about it. I'll talk to Jill Harris, but I don't want to talk to you."
Well, it's interesting because Annabelle is kind of a textbook example of what's known as anticipatory anxiety. And if anybody knows their ancient Greek parables, it's called the sword of Damocles. It's kind of the dagger that hangs over your head, just ready to drop. It's a concept that's obvious, but it's also one that's really underappreciated. And I want to ask Dr. Werner-Lin how it manifests and why it's so important to talk about.
Thank you, Jill. I just want to make it very clear, too, that I am not a physician. My doctorate is in philosophy. I'm a social worker by training and a clinical social worker at that, and my training is in family therapy and in parental loss and grief.
I think you have a place here.
So that's where, I'm not saying you don't fit. I just want to make sure that you're not getting medical advice on this side of the road. And the idea of anticipatory loss or anticipatory anxiety is the experience of having expectations about what's coming down the pike in your direction, of what your future could, might, will hold. And as a species, we're very bad with ambiguity. So sometimes it's easier to think bad things are coming when those percentages are questionable or uncertain. And then we live in that space. And what living in that space of anticipating change, anticipating loss, anticipating end of life, whatever it is, anticipating a diagnosis means we are regularly rehearsing it. We are already addressing and grieving those changes, whatever those changes may be, when nothing has actually happened yet. To us, to our own body, to our own, the sanctity of our own bodies. What I would guess, though, with Annabelle is that hers is very intimately connected to yours. And so we often see this with children when, starting from very, very young ages, that they look to their parents for guidance about so many facets of the world. And one of them is what their health will look like, and what their longevity will look like, and what their well-being will look like over the long haul. And when we look to our parents, and our parents have faced significant challenges, we often anticipate, expect, prepare, plan for those challenges for ourselves. And I can see parents and children in here. This is unfortunate for you that I am a social worker, because I look at a lot of that nonverbal body language. So parents, stop making eyes at your children. I know where you are. But this anticipatory loss is something that happens with young adults like Annabelle, but it will also happen for you as you consider what her future might look like. Right, and you 100%. Consider what challenges she might face, and what her test results might be, and what her screenings are going to look like. So often what happens is that these are happening in parallel in families because it is hard to talk about. And so these experiences of anticipating change across the spectrum of possible changes in this space are often experienced in isolation. And so one of the things that I like to do is help families get on the same page. What is it you're afraid of? What is it you're hoping for? What is it that you are looking forward to or fearing that could potentially be coming down the pike in your direction?
I think there's also a fear that we're going to disagree.
Yeah, that was actually my next question was, what happens? You have your own opinion about what you want for Annabelle.
Right.
She might have a different opinion. And can you briefly tell us how that,
I think that's why it's so heated.
Yeah.
And, she's going to have to come to her own decisions. And I know intellectually she's going to have to talk to genetic counselors and look at her risks and make some decisions. But again, because I know what could be coming down the pike, I have strong feelings about what I think the answer is, but it's not going to be my decision.
Right.
So perhaps she's anticipating that to be, or I don't know, it could be.
It's challenging. And I think we're going to see this later.
Just one quick thing on that. I have a family where I take care of 4 sisters, and we actually literally, I had to counsel them that they had to not talk about this because they all disagreed so much on how they were individually handling it that they had to call a truce over Thanksgiving.
Yeah.
And I'm sure that you've seen that before because and I took care of all of them. So they were all talking to me and complaining about the other one, and I was like, okay, you guys need a truce for a little while. So
sounds like politics. It is really a loaded and consistent topic that comes up again and again, and we'll see it also, Heidi, in your story. But really, how do parents of adult children balance what they want for their kids versus what their children want for themselves?
So I would start by saying the conversations can start much earlier on. It sounds like you and Annabelle have been talking for a very long time about this, but the nature of the conversation is changing as she reaches those ages where she might start to feel like her body is at risk and she's going to have to make some decisions. So when those conversations can start earlier, kids recognize when things are going down in the house. They can sense that the emotional tenor has changed. They know when anxiety is up, when worry is up, when distress is up. And when they don't have information starting from very young ages and they can read that things are off in the house, they often make up stories on their own about what's going on. So from a very early ages, you can start having conversations with kids about how people are different. I know we're going to get to this later, Jill, so I won't get to this now. One of the things that I talk to parents about is expecting, not fearing, but expecting that you're going to have different opinions. Let's put it on the table that, let's start from that, which feels like a worst case scenario. Yeah. Because the things that adult children often worry about or fear are very different than the things that their parents are fearing. So the losses that they are anticipating are often quite discrete. As you said, your daughter wants to have a career and she wants to have a partner and you want her just to be around, right? So it may be much more streamlined what you're hoping for her. Whereas what she's hoping is much more varied, and developmentally she's trying to find her way in the world. So our starting point is anticipate differences of opinion. What we need is not to be on the same page. We need a way to talk about not being on the same page.
Yeah, and having that expectation, you'll be more
having that
successful.
Expectation, that certainty that we are going to come at this from different angles, with different challenges, with different fears, with different hopes, and have that be okay. and then figure out a language, because we often don't have language to talk about this stuff.
Right.
We're inventing it as we move along in the world.
And that's what we'll get to in a minute. Thank you. I wish we had more time to talk about Susan. We're going to move on to our next panelist, Vassar Young Leadership Council member Jenny Sorin, who gives us, with a great deal of depth and introspection, a daughter's perspective of BRCA. Jenny, your mother, Helene, was diagnosed when you were just 8 years old, and a lot changed for you very suddenly. Can you tell us about what that was like for you and what happened to her in the subsequent years?
Yeah, so I'm thrilled to have learned the term anticipatory anxiety, because it feels like that sums up my life. So my mom, who's here, she's right over there, she was first diagnosed at the age of 40. I was 8 years old, and she went for her first routine mammogram with no known family history of breast or ovarian cancer. She and my dad were shocked, like Susan, shocked to learn that, a malignant lump was detected in her breast. And now looking back, I've, learned through mom and dad that they really entered fight or flight mode. My mom was going to tackle the physical battle, and my dad took on the role as her advocate, spending countless hours researching everything that he could get his hands on. This was 2001. And as Susan said, the BRCA1 and BRCA2 mutations were relatively recently discovered. And my dad insisted that my mom be genetically tested, although it was not recommended by anyone on her medical team.
Wow.
And so when her test came back positive, this dramatically changed the course of her treatment plan. So she went from what would have been a lumpectomy to chemotherapy, a double mastectomy, and an oophorectomy, launching her into early onset menopause, all by the age of 41. And, when I think back to that time, obviously, and I'm sure, this panel can attest to this, but I was 8, my brother was 5. I have these kind of images of things that come to mind, but it's very hard for me to remember specifics. I remember, my parents' closed bedroom door kind of acting as this barrier between my world and my mom's world. I remember this feeling of shame, like this fear of stigma around having an ill parent. But I do remember the day that my mom told me that she was sick, and I don't remember what she said or how she said it, but she took me on a carriage ride through Central Park. And I remember the environment that she created in order to tell me whatever way she framed it. And now looking back, I realize that I think that my parents' approach was to keep their kids as safe and protected and shielded as possible. And tonight, of course, is about family dynamics. And in that same spirit, my grandparents, my mom's parents, left their entire lives behind in Boston to come be my brother and my caretaker. Talk about a complicated family dynamic. I was incredibly close to my mom's mom, often at the expense of our relationship. I think that I felt sad and kind of confused that, like Annabelle, like, why was my mom's body different than mine? Going to Victoria's Secret and shopping for bras, my mom never needed to buy one. And so, I kind of just internalized a lot of that. And when my mom's cancer returned at the age of 21, I was 21. Her cancer returned 11 years later. And that time was a very, very different conversation in terms of what my parents were willing to share. But of course, did not make it any easier, given that we had already lived through that initial diagnosis and really those debilitating surgeries and treatments that left my mom really, as a really young parent, unable to care for her 2 young kids at that time.
Yeah. There is so much to unpack about Jenny's story. One thing that you had said to me was that your mom said to you, or someone had said to you in the family, Mom's going to be just fine. And it made me think about, Dr. Werner-Lin, you have a great term that you introduced me to called genetic diversity, which I thought was a really culturally hip and relevant term. And Jenny's story really begs the question, how can parents like Colleen balance being the pillar of strength that they want to be, but also be truthful in their vulnerability when they're breaking news, whether about a genetic mutation in the family or about a cancer diagnosis. And Susan, I know Dr. Domchek, you have some thoughts about this too, I think. Yeah, so.
Thank you for sharing your story. I spent many years working with kids 5 through 8 through 21 whose parents were sick and teaching them this language. I think one big thing that I want to take away from your so eloquent speech was the idea that you don't actually remember what the words were. So there are ways that the actual words you use almost matter less than creating the environment within which those conversations can happen. That's the piece that's so critical. That's what we call a framing event. And I just want to be very clear, I did not invent the term genetic diversity. That, Gregor Mendel did that,
Whoever says something to me invented it.
He had a jump on me with the Black Eyed Peas and the monks and stuff, but that's okay. But the idea is when kids are very young, one of the things we can start to talk to them about is how we're all different, how our bodies are all different. We're different heights, we have different hair color, eye color, even in the same families, especially as we see greater diversity around us in our communities, in our schools, in our workplaces. The idea is that everyone's body is different, right? Everyone's unique. Some things you'll inherit from your mom, some things you'll inherit from your father, your biological parents. Those may not be the ones who raised you. It may be that your grandparents are the ones who step in and complicate that relationship. And boy, we are the only species with in-laws, by the way. And I think that merits mentioning at this particular moment. But it's important early on to be as honest as you can and to answer the questions that are asked by the child. So we often feel pressure to give kids lots of information, or even young adults or friends. Listen to what it is they're asking for. Often kids will ask a question like, who's going to take me to my eye appointment? What they're really wanting to know is who's going to take care of them. What is underneath the questions that they're asking? Before that even happens, we've got to get our heads around our own healthcare, about what having a mutation, pathogenicity was one of my great achievements, being able to say that quickly in a sentence, to get good with how we feel about our own bodies and what our own risk is before we can have a conversation with our children about what it might mean for them. Because then our feelings and our experience and our hopes for our children are going to drive the conversation rather than the child's needs. And that remains important throughout the life cycle, no matter how old your child is to feel like the decisions that you're making for you are yours, and you're good with those. And then the decisions that your children will make will be for them. You may get a say, you may not. But finding that space, whether it's a carriage ride through Central Park. In my house, my kids know that whenever they come to my office, which is the therapy space in the house, that something big is going down, right? That's the that's the room. But they become these physical spaces that become imbued with meaning, or these moments that you don't forget. I don't remember I don't remember what my mother told me when she was first diagnosed, but I definitely remember where I was sitting. Right? But I don't remember what she said. And parents often worry about making sure they get the language right. And I think in the end game, opening up the conversation and having a process around discussing these issues is more critical than the actual words you choose to use in that space.
I mean, the only thing I would add, because it was beautiful, is that, and this is hard for me because I'm an oncologist, and what we want to do often is lie to our children and tell them that everything is going to be fine. And life isn't like that. And so what I often am talking to my patients about who are sick is how to use words that don't lie, but say things like, I'm getting this treatment because, I'm trying to get better, or I'm getting taken care of well. but not like, I'm going to be fine. Because then, especially younger children, when they see mom isn't fine, like they're throwing up, or we try not to do that much anymore. We have much better drugs, just as an aside, but are tired or not able to be the person that their child wants them to be, that feels like a lie to them. So we try to work on a different way of talking about it, that things are hard right now, but we're trying to get to a different place. Or things are hard right now and they may not get better. And these are really hard conversations, but all I can tell you is that there are resources available. Like we really, there are ways to find out help about how to have these conversations. One of it is just this, but there are others.
Yeah, and the language is so important. Jenny, when your mother's cancer came back, you were in college, and the focus was obviously on her. I am sort of fascinated in life by those moments of recognition where your mind kind of locks in when you suddenly get it. Do you remember the moment or the time when you went from being worried about her to being worried about you?
Yeah, and I think, Jill, something you and I have spoken a lot about is how, my entire life, from what I can remember, has really been colored by our family's experience with breast cancer. My risk perception was everything that we had been through as a family, and my mom's vulnerability to this disease and my own vulnerability were the major motivational factors that led me to the decision to have a preventative double mastectomy at the age of 25. And, I think that risk perception plays a lot into this, specifically for, BRCA mutation carriers who have watched a parent like I have from such a young age. But once I got my positive diagnosis, to this point, I really wasn't surprised because I had been expecting it. But my mom and I spoke a lot about, and Susan, this is like your future here. Like,
Thinking that.
my mom and I spoke a lot about, weighing the pros and cons of surveillance versus surgery. And I have no doubt that her own feelings about what she wanted me to do were really heavily influenced by her own experience. But she really let me come to the decision on my own terms. I spent about 15 months going back and forth between mammograms and MRIs and ultrasounds to screen for my cancer risk, all the while, doing my own research like my dad had and talking to so many women within the Vassar Center community, helping me realize that, this decision wasn't as scary as I thought it was. And I really wanted to take the information and the knowledge that I was given, and not have this fear inside of me anymore that the same thing that happened to my mom was going to happen to me. And so I feel this great sense of relief, as hard as it's been, and I know we'll get into that, but I do feel, this sense of relief, and that the decision was really made by me with my mom's support.
This is an interesting question just from a clinician standpoint. We've all been in that situation where we go to a doctor and we say, what would you do if you were me? And Susan, it's so interesting within this context to wonder what you tell patients, especially young patients, who ask you that.
Well, Jenny, I think you said it so well. Everyone comes in with their own lived experience, which is going to impact their decision making. Yep. And I really try hard not to specifically answer that question because, and if people push me on it, I will actually tell them that I had a relatively simple surgery when I was a resident that actually led to me having some longer term complications that then required me to have a really big surgery. And so I have my own lived experience, right, and I have my own issues that I would have to deal with, which is I had unanticipated complications, right? Not related to this, but that's my experience, and I don't want to color anybody else's experience. So, yeah. And we see it over and over again. People with if they have tons of breast cancer in the family, that's been horrible outcomes. That's very different than multiple family members did fine, or not many people have had cancer. Of course, that's going to color how you see this. And so that's to be considered.
Yeah, it reminds me that we often think of ourselves as thinking people who occasionally have to deal with feelings, but we're really feeling people who occasionally think. We're really, really driven by experience, like we're all Pavlov's dogs. Anyway, so tonight is all about relationships, mother-daughter relationships, multi-generational, through parents, grandparents, even sibling relationships, which we'll hear with Heidi's story. But there's another relationship that I want to talk about, and it's the relationship to our bodies and our identity. So Jenny, your decision to have a PBM, a prophylactic double mastectomy, has its challenges, and you've written about it beautifully. So I'd like you to tell everyone about your experience and what you've gone through.
I feel obviously grateful to have Jill, who's a journalist, sitting here saying that to me. I think that it's not a myth, but I think that there's this perception for BRCA mutation carriers in particular who have not had cancer that, once you decide to remove the breast tissue or once you decide to remove the ovaries, you're in the clear. You've made this really hard yet really rational decision to significantly lower your cancer risk, and you did it all, preceding chemotherapy and radiation, and you should just be grateful for the fact that, you didn't have to endure those really, really hard treatments. And first and foremost, I am so grateful. I am incredibly grateful to science and to the Baxter Center for making genetic testing possible, for having access to this kind of information, and having the great privilege of being able to choose a medical team that I felt really comfortable with. And, I want to acknowledge my privilege in that. But there's a but there. And that is that, to be 25, to still be figuring out your way in the world and what your purpose in life is, and to be forced to figure out a future that I hadn't even begun to contemplate, finding my life partner. I think about today, I'm getting married in a couple of months. How bad will it sting when we ultimately decide to start a family and my body is not able to produce those nutrients that my child needs? Or, the realization months after a double mastectomy that, all sensation and my sense of intimacy in my early 20s is completely altered. So, I think that in comparison to having cancer and withstanding chemotherapy and radiation, those pale in comparison. But as you talked about, complications don't materialize until they happen to you in real time. And I have certainly endured complications that I did not expect when I first made the decision. And that includes, general things like post-mastectomy pain and, scarring and just general lack of mobility. And that also includes, rippling that led to an unexpected revision surgery. So I think that what resonates most for me, and something that Jill and I have spoken about, is that both things can be true. I can hold these two truths at once. And on one hand, I am so incredibly grateful to have had the experience that I had and to know that I've significantly reduced my risk of cancer, yet I'm also incredibly sad. And there's this sense of loss and mourning that I am still working through. And I think just being able to hold those two truths at the same time has gotten me to a much healthier place today.
Yeah, well done. Yeah, very well done. And I think that you bring up something that's so important. It's kind of taboo in a certain way to talk about that because you are so grateful, you are so lucky, and it's also hard work. Yeah. And it's also a process, which leads to my next question for you, Dr. Werner-Lin. How can carriers process this kind of grief? Because there's, tremendous kind of feelings of loss wrapped up in the gratitude.
I think the first piece is recognizing that it's grief, right? So that we can hold those two extraordinarily profound emotions at the same time. There are a lot of ways to work through it. One is to recognize what your body can do, right? And there are things that your body won't do and can't do. And we'll find substitutions and workarounds, but that's not going to change the experience of loss. It's still going to be a profound experience of loss. You will need your good friends around you when that person says, "What, you're not breastfeeding? What, do you not love your baby?"
Don't get me started.
Right. So, I mean, I'm going to turn back around from what I was going to say. So those spaces in having some people who are close to you, who know where you are with your body, how you feel about your body, how you feel about your body in the world, and how you feel about your relationship with your body is critical. It's critical for your partner. It's critical for you. And by now, Jill, I've forgotten what the question was.
I think you answered it.
Did I?
I think you answered it. Dr. Domchek.
Just really quickly. So first of all, I'm getting beklempt because, but it's just, one of my patients once said to me, knowledge of this mutation both saved my life and ruined it. And to me, that just like summed it up so dramatically.
Yep.
And like when you said holding these two things at the same time, I mean, I'm going to use that because it just really, it sums it up. So thank you for that.
Thank you. We're going to move on to Heidi Rieger, a Bassler Center Advisory Board member whose inspiring voice and story shows us how BRCA moves through and across families, generations. And Heidi's experience is a great reminder, and I wrote this out and I want to put it on t-shirts. There's no one way to do BRCA. What's confusing and confounding to some is crystal clear to others. Can you tell us your story and how it all came down?
So towards the end of 2015, I was 58 years old. My breast doctor at the time said to me, I think you should get genetic counseling. And I looked at her and said, what's changed? My family history hasn't changed. And she said, the testing is really sophisticated. I think it's a great idea. I walked out of the office and I was about to go away to celebrate my 30th anniversary. I really opened the drawer and then I shut it. And then towards the end of 2015, I was with a friend over dinner who had just had breast cancer, survived. She was BRCA positive. She basically said to me, you have to get tested. You have 3 daughters. Knowledge is power. This isn't even about you. It's about them. I was like, okay, I'll do it. So 2016, I gather all of my family history. My husband, Richard, who's here tonight, we go talk to the genetic counselor. I give my arm, I give my blood, I walk out, and I'm usually one who's prepared for the worst. I really didn't think about this because I didn't have cancer. My mother died of cancer, at that point 20 years ago, but it wasn't under the BRCA umbrella. So 3 weeks later, when she drops this bomb that I was BRCA2 positive, it was devastating. But by the time she was done setting forth the options for me, it was very clear. And then 2 months went by, and 40 days later, I had 2 surgeries. I had a prophylactic double mastectomy, and I had my ovaries out because at that point, I was 58. Mm-hmm. And talk about feeling grateful. I basically lived my life having this mutation, and it didn't harm me. So, but my 2 older daughters were of age to get tested, and my middle daughter is actually a genetic counselor and also has a dual master's in biomedical ethics, so she was arms up, getting tested. My eldest daughter flew in from New Mexico, and I remember getting into bed every night, bartering, praying to a God I wasn't even sure I believed in anymore, and thank God they both tested negative. At the time, Lyris Schoenheltz, I know everybody loves Lyris, she says to me, what, your 91-year-old father is still alive? You need to get him tested yesterday. So at that point, and my dad was a doctor, he was not, totally with it. He came willingly into Manhattan. He had no idea what he was doing. And I got the mutation from him. And he lived to 96 without a day of cancer in his life. So I hang on that, but as it turns out, on his side of the family, there is a lot of BRCA-related cancer, and that's, it makes sense. So fast forward, my youngest daughter, who at the time actually wanted to get tested, but she was 20, by the time she left the appointment with the genetic counselor, she, talk about anticipatory anxiety, she made the decision, if God forbid I'm positive, no one's going to really do anything, and I have to sit with that. Okay, so fast forward September 2020. Talk about remember exactly where I was when she called and told me she got the news that she tested positive for BRCA. And my line, and I'm going to say it nicely, fuck with me, don't fuck with one of my kids. And I'm sorry, I hope I didn't offend anybody, but that's...
I think we may have heard that word before, right?
But I mean, I really wanted to go to the grave with this and let it down. So her journey, and I have to tap, her journey has been one of a roller coaster ride because she was basically living the life that I opted out of at 58. And talk about at the beginning of your life. Anyway, every time she had an MRI or an ultrasound, because she had this red flag on her chart, she was getting biopsies where for other people, they would say, we'll just watch it. No. And in her mind, it wasn't just the making of the appointment, the going, the getting the results. You have to come back for the ultrasound. It wasn't just one day. It was 3 weeks of being derailed. And thank God, none of it's been anything.
Yeah, but that's an interesting experience that I think is also one that's consistent. And Dr. Domchek, I think that mutation carriers can, in the medical establishment, have a sort of scarlet letter A, or in this case, BRCA, put on their, attached to their charts. And doctors have a sort of hypervigilance for cancer, which often comes with a lot of anxiety of additional scans or biopsies or the 3 weeks that you're referring to. How can patients balance that, and how can they talk to their doctors about it?
It's such a great point, and we do know that some women choose mastectomy in part because the serial scans are just overwhelming in terms of the anxiety, and even if they're normal, just the anxiety of getting them and waiting for the results. There's a few things. First of all, it's really important to set expectations, and I know that seems to be a consistent theme, but when someone their very first MRI, there's a 25% chance that they're going to need another one in 6 months. And I tell them that, and I'm like, that's just because they're getting to know you. It's almost certainly nothing, but just know that that's really super common. And biopsies, less than 20% of the time is biopsy positive. So we have to follow those things up, but we just need to set the tone right away, which is how likely is this? What are we getting ourselves into here? And usually we can go through a first phase where people get a lot of, they don't know what things look like, so the radiologists want to see a few versions of it. And then oftentimes it slows down and people get on a more steady state. So I do try to get people through those first few scans just to say, how does it feel to live like this? Jenny, you did this. You said, how does it feel to live like this? And for some people, it doesn't feel right. And for other people, the benefits to them of sexuality and their body image and breastfeeding outweigh those issues. And I mean, individual decisions.
Heidi, one of the things that you talked to me about was your father was 91 years old, but you said to me, if he had known that he had passed the gene on to me, he would have been devastated.
He would have been shattered. And it was one of those rare moments for me where I was actually grateful that he wasn't all there, because he was spared. Because that's what I'm living with right now. And I let this daughter of mine kind of be my North Star and my barometer. When she's good with this, I'm able to live her truth and know that I modeled behavior of doing what I did, and then the choice is going to be hers. But when she's derailed and a mess, I don't actively act like I'm a wreck in front of her, but at night I take it. Yeah. I take it with me, and it's part of my demons that I have to live with. And I am grateful that my dad was spared that.
Allison, this is very common to have this tremendous sense of guilt. It's almost, for many people, it's the heaviest part. It's the heaviest part of BRCA is passing it on to your children. It's like this profound sadness, but there's also shame. What do we do about it? How can you help patients get through this?
Thank you. It's such an important question. The first thing that I tell parents when I talk to them is that this is one thing among millions that your children will inherit from you. They will inherit so much of your personality, your love, your passions, your interests, your proclivities, your sensitivities. This is one piece of a very large, complicated, and ever-evolving puzzle about how your children will navigate the world. I have a lot of parents who come to me and say, I want to do everything I can to protect my child from experiencing any pain, any sorrow, any sadness. And I have other parents who come to me and say, I want to help my children develop the skills because I know there's going to be sadness in their lives. I can't stop that and I can't change that. And I need to help teach them how to live with that. And so a critical takeaway from that piece about guilt is that this takes me to what you said, Susan, about this was a gift, a blessing and a curse, to know. This is not an experience of control. You don't click a switch and decide that this is a part of your DNA that you're going to pass on to your child. That's just not the way it works. But the generations now of people having children, right? Now that we know that this is in there, it's as if we are somehow responsible for it. We are not. This is the way that reproduction works, right? And we have to think about that mutation in the context of all of the other gifts and challenges, biological, social, multi-generational family dynamics that we leave our children and that we teach them to navigate over the course of their lives.
Heidi is a representative of somebody who's like a mama bear kind of protectionism for her children. This kind of strength-based approach to things. How can we cultivate it or purchase it?
You can purchase it from a local social worker near you. I say this as a mental health provider. That guilt, that shame, it's going to evolve over the course of your life as you watch your children make decisions, as you watch them grapple with struggles that are related to BRCA and that are not. There is no shame in asking for help. And there is no shame in going outside of your own social and family network and asking for that help and finding someone who does not have a vested interest in the ways that you make those decisions. Someone who may know something about the area, but who wants to help you make the decision and navigate things in the ways that are best for you. And I think that's critical. So I do advocate for mental health support, someone who is experienced in illness and caregiving, who understands how kids see what happens in their households and then create future narratives for themselves and then make decisions based on those narratives so that they play out in very specific kinds of ways. Did you want to?
Well, I wanted to ask Susan.
Yeah. I just one quick thing, and I'm not going to put Jenny on the spot because I didn't ask her this question. But when I take care of a lot of women that are now my son's age, which is weird, and I just feel old, but it's just true. And one thing I have never had reflected back to me is that it's their parents' fault. Never. Once.
Yeah.
That's never the narrative. It's always, that's not meaning that they're not concerned or thinking ahead, but that's just not part of it. That's not what they think. And so there's laughter over there, so maybe that's not always true. Maybe they just don't tell me. So, but I just don't, I think people learn about genetics and they just kind of view it as just a piece of them, and they don't really view it as a blame thing. But again, that's my perspective.
No, and I agree completely. I have never heard a kid say, I wish I wasn't here. Right? Because that's what we're talking about. Would it have been better if I had not been here? And that's never the case. Yes. There's extraordinary value in every life, in this room, and in all over the world in the BRCA community. So I think it's important to keep that in mind. That even though that's the way we may feel as parents, and I'm a mama bear too. Mine is thou shalt not fuck. It's a little more biblical than what you were talking about.
Say it again.
Thou shalt not fuck. With the babies, right? You want to protect them. Of course we want to protect them. That's what parents do, right? We want to protect your children from the evils of the world. And there's a lot of protection we can do, and there's a lot of building up their confidence, because confidence is something that is often damaged when a child has a parent with cancer. They think of themselves as being different. They think of themselves as being an odd duck out, or different than their social network, than their peers, that there's something wrong, right? That they're somehow less than. But I have never heard a young adult say to me, I wish I weren't here.
Dr. Domchek, what about the sense of courage, and how important is it for patients to figure out how to get there, or how does courage impact the clinical, like the arc of a patient's illness experience?
Well, I think it was said before, that there's not a linear path, and I think that's something we really try to emphasize, that this is a journey, and that we also try to emphasize that these risks that I mentioned in the beginning are not today's risk and tomorrow's risk. They're risks till age 80 and 85. These are lifetime risks, and it is this lifetime journey. So that decisions don't need to be made quickly. You can take your time, you can talk, you can gather your troops and gather your family around you and get that support. I think that one of the most impactful things is for women to talk to each other about the good, the bad, and the ugly, because I always say that I give people information and answer all questions, and that individual decisions, there are just so many pieces in that, and things are more or less important for people, and how those things are valued. That's not for me to say. I'm going to give information. What is your risk today? What's your risk this year? What can you do to minimize those risks? How can we detect things early? But yeah, it's courageous to do surgery. It's courageous to screen. It's all of these things, taking these decisions on, it's really empowering, but it's also hard.
I just want to end this portion by asking Dr. Domchek, because this has to do with optimism and hope. What areas or specific innovations carry the greatest hope for BRCA mutation carriers?
Yeah, so this is where we're going the next 5, 10, 15 years is this concept of cancer interception, which is trying to prevent these cancers from developing the earliest possible stages. And there is a clinical trial that is actively open in the United States now, looking at a bone strengthener medication to prevent BRCA-related breast cancer. Again, we're really 10 years away from knowing whether that works or not, but it is actively being given to people. It's going to take 2,900 women around the world to agree to participate in this study, which will be randomized to the drug or a placebo. So it takes a lot of strength and courage to enter these trials. Yeah. We have a vaccine trial that is open where that's in earlier stages, and that potentially could prevent BRCA-related cancers, breast, ovarian, prostate, pancreatic cancer, again, earlier stages. And we have hopes to take these new medications, these PARP inhibitors, into prevention. But again, there we need more work to do. But those are 3 very concrete examples of what we might do, and others coming down the pike.
Yeah, that's great to know. So it's time for the Q&A portion of the evening, and I have a question that I'd like to ask about PGT. Dr. Werner-Lin, one of the greatest challenges is making, for people, for carriers of childbearing age, is to how to manage the pressure of new technology. We think about pregnancy and genetic diversity as governed by chance. So how can women think about in vitro fertilization and genetic choice through PGT, which is pre-implantation genetic testing?
I feel like, Susan, you should start this one.
Yeah, either
do you
or
wanna
both.
start this
Yes,
one?
yes, both.
I can start, and then you can pick up the,
Okay.
so this technology is available. Partners can go through this process, but here's the trouble. There are easier and more fun ways to get pregnant that are much cheaper. And if you go through pre-implantation genetic testing, you can be a healthy, completely fertile couple that would have absolutely no trouble having children, and you can go through pre-implantation genetic testing and end up not getting pregnant. And it's important for people to kind of go through all of this and what it entails, because it does entail a lot. It's shots and ultrasounds and blood tests and retrieving the eggs and fertilizing them. But just to kind of give you a sense of math, if 15 eggs are retrieved, and if 12 of them fertilize, and if 8 of them look good on day 3, it's possible that 2 don't have a gene mutation. So that's and sometimes you have 10 that don't have a gene mutation, but you can left with 2, which means doing it again. And what is really important is just to kind of, again, anticipate, look ahead. How's that going to feel? Talk to your partner. Do we want to do this? Do we not want to do this? It's just a lot, and we're here to help. But it's, understanding exactly what the process is, what the costs are, emotionally what that's going to do, and also with your partner saying, okay, if we end up and it didn't work, how do we feel about getting pregnant naturally after we tried this? So I try to take people through that whole arc so that at the end, it's, it's okay, but you really have to think through all of it. So sorry to ramble a little bit.
Thank you so much. I think one of the pieces that's critical here is thinking about this scenario, reproduction that's, we think of typically governed by chance, and that PGT has introduced choice, right? The same way that prenatal testing did many years ago. And those, we think of choice as being wildly unencumbered, but that's just not the case. That the majority of women who do get pregnant with BRCA mutations go the conventional route. It may be because they learn about the cost, the emotional cost, the physical toll on the body. But it introduces, the availability of the technology introduces in and of itself pressure to avail yourself of it. And then it's, if giving birth to a child and finding out eventually that that child has a mutation can feel like a failure. That's where guilt comes in, because you made a decision not to engage with a technology that could have, might have, would have. And those are really big question marks. So all of these pieces require prospective parents to sit with a level of uncertainty that can be really uncomfortable.
Yep.
That can be really uncomfortable. And not only does the couple need to be on the same page, or the prospective parent to be really sure about what they want to do as they become parents, there are grandparents. And I'd like to reintroduce the idea of in-laws, right? So there are a lot of people invested in the health and well-being of this future child. Think about how much love that is, right? There is so much love that this child already has before they are even conceived and a part of this world. But again, this is one choice that parents will make that will shape the nature and course of their child's life. And it's important to contextualize that.
Mm-hmm. Thank you. So here are some questions from people who have written in. Dr. Domchek, can you comment, I love this question, can you comment on any research that's been done on BRCA mutation carriers who don't develop cancer? Do we know any specific factors that are protective?
It's a great question, and we what we know some. We have looked at things, genetic modifiers. They're called single nucleotide polymorphisms, or SNPs, and these are changes in the genetic code in other genes, not in BRCA1 and 2, that are pretty common in the population, and we know about 300 of them related to breast cancer now. So in the general population, if you have all 300 bad copies, your lifetime risk of breast cancer again, in the general population, maybe 20%, as opposed to 5% if you had all the good copies. So this has an impact in BRCA 1 and 2 as well. So the people who don't develop breast cancer are more likely to have those good copies, but it's just not 100%. So that's the problem, is that we still haven't been able to figure out that group of patients who has like a 10% a likelihood of breast cancer. We're not there yet. We're still working on it.
Okay. Here's a question about birth control and BRCA risk, and asking if you can recommend birth control options for teens who don't know yet if they are a BRCA carrier or not.
So the way we talk about birth control is, first of all, in this day and age, yes, birth control is particularly good, and long-acting, sorry, just to inject a little bit of politics. Oral contraceptive pills do good things and bad things. They decrease the risk of ovarian cancer. They may slightly increase the risk of breast cancer, but it's not magnified by BRCA 1 and 2, if that makes any sense. And birth control pills really are with current and recent use. So if people use birth control pills when they're younger and stop, we're still investigating this, but the highest risk of breast cancer in BRCA 1 and 2 carriers is in like their late 30s and 40s, at which point a lot of people have stopped their birth control pills by then. And also, again, it decreases ovarian cancer risk. By the way, it prevents you from getting pregnant, controls your cycles, lots of good things. That's the reason people take them. It also does other bad things, like there's an increased risk of blood clots. So we just view it as there's no contraindication to birth control pills, so we do not feel that people need to get genetic testing to determine whether people should go on them or not. Now, long-acting reversible contraception, IUDs, are actually much more effective than birth control pills because no one forgets to take them or it's not interfered with antibiotics. So that's another really good option for patients, whether or not that's with hormones like Mirena IUDs or without. Copper IUDs have no hormones, but people tend to not like them as much because there's more abnormal bleeding. So the long story short, though, is that there's no contraindication. The question should be, why are we talking about birth control, and then having the right method for that.
Thank you. Dr. Werner-Lin, what's the right age to have a conversation with young children about a BRCA mutation in the family and talk to them about the possibility of inheriting it?
No right age. There's no right age. It depends on so many contextual factors. So if there is a cancer active in the household, it's time. Right? If that cancer has provoked the conversations around genetic testing, the conversation doesn't need to be around genetics at that point. It has to be around cancer and the changes in the household. However, in light of this, the idea around a strengths-based perspective, you can start talking to your kids really young about the ways that you're different. So one of them that I love is the idea of who can roll their tongue, right? This is genetic, right? She can do it. But that does not necessarily mean your kids can do it. Maybe they can, maybe they can't, right? Can't? Can't. Right? So that we are all different in those ways, right? So we can start earlier before the genetic testing around breast cancer begins to be a part of the conversation. We can start talking about the ways that we are the same and different from our parents, the ways that bodies are the same and bodies are different. Those conversations can happen very young. Before the age is about 5, 6, 7, like first, second grade, kids don't have a sense of time or geography, right? So a lot of the language we use to talk about illness or the length of time that someone will be gone or away or who will care for them goes right over their heads. But you can identify visible things like the roll of the tongue at those young ages to plant the seed for conversations around differences in genes across the family and across social networks and across communities very, very early. It's the critical piece there. The takeaway I would say is that it's time for the conversation when it's time for the conversation. If something is happening, it's time to get talking.
The one other piece I'll say is that most high school biology textbooks now talk about BRCA 1 and 2. So almost all of them do. So your kids may come home with this. And so my older son and I had a heated conversation about the definition of a mutation, and he insisted that I was wrong. So that was fun. But that is just another warning, is that they get it in science class. So.
All right.
And to follow up on that, it's better that they get it from you first. And if they get it from you first, it reinforces trust, and that they know that if something big and important is happening in the family, that you will come to them them and let them know so that they won't be caught off guard. If you don't bring it up with them first and they find out in high school biology class, they will wonder what else.
Happened.
It has happened, yes. What else you might be keeping from them.
Right.
So it's better to have those conversations earlier to develop that foundation of trust and to keeps the platform open for conversations moving forward.
Wow.
But if you didn't do that and your kid did come home, don't worry about it. It's okay. There are reparations.
This has been an amazing night. Thank you, Dr. Domchek and Dr. Werner-Lin, for being so informative and supportive. We all know what it means to have a doctor who is generous of heart, who does the care and the caring for patients. So thank you to our very inspiring storytellers, Susan Getz, Jenny Sorin, Heidi Rieger. Thank you. This is such a tremendous, tenacious community. Empowering each other and really lifting each other up. And you guys all show us that it's not the burden you carry, but how you carry the burden. So thank you, and thank you guys all for coming.